Welcome everyone. Today's program is the conditions of participation from CMS for acute hospitals. And we're now in part 2 of a 5-part series. So today we're going to move on to a couple different topics and one major one in particular. That is the subject of patient rights. So as you can see on slide number 1, we are covering major areas for today. If you haven't listened to any of these programs in the past, this is the reason that we do this, why these programs are being presented. It's so you do not get one of these. That is the statement of deficiencies when CMS has come out, done a survey, and found something that's not there, or it's not enough of it there. And then, of course, you have to submit your plan of correction. To start off, you want to subscribe to the Federal Register, include your email, and then they will send you updates. Now, that could be updates of notices, rulemaking, or actual new rules. One other thing that's nice that you can get access to is what did CMS find on these surveys? What were the deficiencies, the citations? And these are the ones, these are the top 6 deficiencies in the areas we're talking about today. And then we split it out. These are specific tag numbers. Now, they did make some changes in patient rights. And the funny thing was they put it in a memo called discharge planning. That's where they put it. All right, let's go ahead and start talking about some rights. Other contents of the Notice of Patient Rights is confidentiality, privacy, pain relief, the right to refuse treatment, right to have and obtain informed consent from them. One of the patient rights, I mentioned it before, was when you have a non-English speaking patient or a patient in addition to that who might have a disability. Under OCR, Section 1557 of the Affordable Care Act, there were some changes that were made back in August of 2020. Okay, grievances, also known as complaints. Remember, this was one of the higher levels of the deficiencies. That is a formal or informal, written or verbal complaint. So here's just an example. What is a grievance? What is not? Check your website. This is for KEPRO, by the way, for the quality of care. You will also hear the 7-day rule. That's considered appropriate. Now, if a patient emails you a grievance, you can email the response just as long as your security team, your IT team doesn't go crazy when you do that. Let's talk about exercise of rights, and in particular consent and advance directives. On informed consent, which is what we're talking about here, be involved in your care and find out what's going on. It's actually 3 sections in the entire Appendix A. Patient rights, which is what we're covering today, medical records, and surgical services. It talks about obtaining informed consent. So it has privacy, advance directives, etc. Let's move on to privacy, safety, and ligature risks. Again, this is one of the highly cited areas. On safety, patients have a right to get care in a safe setting. This is, again, one of the highly cited areas for this section. They updated Tag 144. There were some proposed guidelines. I've included those in the appendix. Abuse, they provide a definition for us. What about confidentiality? We touched on this earlier. So let's talk access. I touched on this a little bit earlier. Well, now we're on to this part about restraint and seclusion for patient rights. Again, very long section on this. So other changes. What you need to include in the internal log. Restraints and seclusion deficiencies are multiple, and you can see all the tag numbers. These are the most recent deficiencies as of January of this year. Now, these do only go to the 3rd quarter because that's all that had been posted, but it's a total of 3,700 as far as how many deficiencies were cited. Now, keep in mind, CMS does specifically state it is not the department the patient is located, it's their behavior. So that is the new definition. Know it. Let's switch over to seclusion. What they do include, these are all restraints. Others, stroller belts, safety swing belts. As long as they are age or developmentally appropriate, it is not a restraint. Safety interventions. Make sure that that's in your policy. Holding an infant or your toddler, again, that's not a restraint. Now, weapons, they specifically state weapons are not appropriate. Here's an example. What's least restrictive restraint to a more restrictive restraint? As far as who can order restraints, this again was a new, licensed practitioners can write orders for restraint as long as it's permitted by state law and your hospital policy. And of course, you have to include restraints in your plan of care. It helps to have that toolkit with documentation in there, has all the requirements. The order sheet could be in there, and then follow the manufacturer. Just put some examples here what some of these restraints look like. So the time limits, this is related to your restraints and seclusion for violent or self-destructive behavior. and that's for the safety of patients or staff. So you may want to think about a separate form for when you have to do this. You can make sure things are covered, the requirements. You have to have a policy on restraint and seclusion. So there are some new staff requirements on education. As far as the training, individuals doing the program have to be qualified, and they must have that high level, document what those qualifications are. Most will do train the trainer program. This was changed a little bit ago, a year or so ago. You report any death associated with the use of restraint or seclusion, and you must use the electronic reporting system. What else? Well, of course, you document the record, the date and time of death you reported to CMS, and that includes those in soft risk restraints. And so we're going to wrap up with visitation. This is a relatively new requirement. You have to have a policy and procedure on visitation rights of patients. Since I'm going to go ahead and close out the program. Thank you everyone for attending, and stay safe. Thank you.